I want to begin at the beginning and ask why colon rectal surgery, and perhaps even why surgery?
Well, surgery was maybe more of a dilemma for me because when I was a fourth-year medical student, I thought I really enjoyed working with my hands, and I loved my surgery rotation. But there weren't very many women, as you know, going into surgery. And so I actually applied for both OBGYN and surgical internships. And not until right before the match, I decided, I'm just going to take a chance. It's 1 year out of my life. If it's really terrible, I'll do something else. And I loved it. And then colorectal surgery was really about that's the part of surgery I liked, that I liked bowel surgery, and I liked the issues that patients have, just intellectually. And watching general surgeons do that surgery, and I grew up in Minnesota, so I had an opportunity to watch Stan Goldberg and some of his partners do colorectal surgery. It was very clear to me that they did it better than any of the general surgeons I had trained with. So that was a pretty easy decision.
You are the first woman president of the American Society of Colon and Rectal Surgeons. Do you think it was the main accomplishments that you might have?
I'd have to think about that really probably to answer it more completely. I think the legacy question might actually be easier because I feel that having had a woman in that role is very encouraging to other women in the specialty, and to see that that it's possible to rise within the society, that there were other women going before them and leading, is encouraging. I think that to young women in particular. I think that probably the specific accomplishments were that we did a strategic planning process that's been done before, but it was much more open and wide-ranging to diverse opinions, because I believe in leading by consensus. And that we had a lot of challenges at that time about our relationship with industry. And I feel that it certainly wasn't just me, but that we at the organization at a time and the leadership were able to find a way to have a balance in which we could help industry and the society could help each other in ways that are good for medicine, good for surgery, but agree to restrict the kinds of interactions that are maybe harmful to either of our reputations. And it felt a little like walking on a tightrope at the time, but I feel good about that we were able to do that.
You were willing to invest a lot of your energy in putting together a structure within the society to encourage women and support women.
Well, as you would remember, that in my early years in the society, we would the women would get together for coffee in a coffee shop, and it'd be one table and 5 or 7 of us sitting around chatting. And it felt very important to me that if we were going to really make colorectal surgery seem like a viable option to female general surgeons, that they had to feel welcome at the meeting. Junior staff had to feel like they had a place to have their questions answered. And that although I'm perfectly comfortable with the idea that there should be equal opportunity, lives for women particularly, in many ways, and then you add professionally, family-wise, just choices women have had to make, that they needed people to talk to and that they could answer, who could help them with those life choices and life structures. So it never felt like a burden to me. It always felt like it was a wonderful thing that we were able to gather those women together and have lunch. which has grown exponentially over the years, and offer that opportunity for people to talk about their careers and their life choices and what practice environment might be easier given what they want out of life. And the last few years, the society has taken over that, the logistics of that, which is a relief and means it'll continue even when I'm not working. But it never felt like a lot of, it was joyous kind of work.
What directions do you see not only the society, mainly the society, but also medicine in general, surgery in particular, us most of all? What directions do you see those going?
Well, I certainly think that the research going on means, whether that's in genomics or the gut microbiota, that it's going to have a lot of impact on what we do, and maybe being able to personalize medicine and surgery to a patient's given much more individualized their care, which is exciting, and it's exciting information that is being learned, and I think we will have to learn what it means to us as surgeons. I mean, it's at the basic science level now, but how that translates into how we care for patients, I think we're going to have to learn. I think there's been an explosion of technology and will continue to be an explosion of technology, and finding the right place in the care of patients for that technology, not that because it exists we're going to use it, but because it really it is an advance in the care of patients, is work the society should help participate in. That it's sexy to use the newest thing, but it doesn't necessarily mean it's the best thing for patients. And then what healthcare in general is going to look like is still such an open question. I think the medical profession is finally realizing that healthcare costs have to be controlled, that it will be done in a better way if we participate. But if it were easy to answer the question of how do you maintain the quality and reduce the cost, somebody would have done it a long time ago. And it's, I think for instance, my young partners, I don't really know what the environment will look like for them. I mean, whether solving those problems is going to mean we're all employed, solving those problems means this model stays, but we have a single payer. I think there's a lot, and the people, I hope young people will be able to see that as a challenging opportunity and step up and contribute to how it's designed, rather than just feeling like victims that outside forces are doing this to them, which is easy to feel.
One of the things that has impacted the way education happens now is this restriction on hours.
I think it's probably interfered in multiple ways, but maybe it all comes under that broad umbrella it makes it difficult for for the trainees to connect to the patients. We have really tried not to have this happen, but I know in general surgery programs, they're leaving in the middle of operations. Mm-hmm. They're not able to take the patient back if the patient needs to go back to the operating room. So they lose both the surgical continuity, but also just the human continuity with people. Al Thorson just now was talking about using the sleep research, that there is a difference in each of our resiliency to lack of sleep, and that maybe using fatigue risk management, we could figure out how to tailor if maintaining that the primary goal is patient safety, how we tailor the duty hours by people's resilience to sleep, which sounds interesting. I don't know logistically how you do that how you do it without making the people that are less resilient to sleep feel inferior. I mean, there are lots of challenges in that too. Whether surgical training is going to be longer because of that. I think we were guilty of thinking we could do anything equally well, whether we were tired or had slept. And that's obviously wrong. And restricting it too far has got unintended consequences. So how we get to this middle point, I think we have to keep working on that.
Is that as the technology and the sophistication of all of this continues, that the humanity, that it is one human treating another human with an illness, with suffering and pain beyond the physical, how can we, as a society particularly, because we deal with delicate subjects, how can we make sure that we don't lose that behind the computers that people type into and all of that?
I think it really is a challenge. It's a challenge when you're interviewing patients that you also are looking at a computer. It's a challenge that what we do is so technically advanced. It's a challenge that the hospital stays are shorter. But I have more optimism lately than I did because we are, in Minnesota, and I think it will come nationally, are being measured on our communication skills and how patients view our communication skills. And it's being, so we just recently did some communication training for our group using a national organization that studies communication in healthcare. And I told the people who complained about having to do it that either you do it because you think it's important to be really good at what you do it because our results are going to be posted on a public website for the state of Minnesota and you don't want to be humiliated, or you do it because it's part of our risk-sharing contracts, how we score on those questions, and you don't want to lose the money. So whatever motivates you, there's a reason to do this. And I think it is something the society could be forward thinking about and maybe offer it at the meeting, help develop specific, even with this other organization, develop specific modules that apply to what we do because you're right, they're sensitive topics. But I think, there really are experts in this, in communication, and I think if we availed ourselves of their expertise, but then provided that as an opportunity for our membership, we could help with that.
The introduction of the stapling devices was a major change in our field, changed everything. Then the introduction of laparoscopic stuff changed everything. What's next?
Well, the thing that's here is the robot, and it's figuring out what the robot allows us to do better than we could do laparoscopically and still maintain the advantages of minimally invasive surgery. But of course, what they're talking about is taking things out, doing colectomies and removing the specimen through the vagina or the stomach. And it seems, I guess I'm old because it seems wild to me that we would be doing that, or even really that we'd want to do that. But I think that's one goal. And the other, I think, is what I mentioned before, that if we understand more about the science of the biology of the gut and our genes and how our genes impact the progression of different diseases, that we hopefully will be able to do more individualized care for patients. But it means you have to relearn all that microbiology because it'll be completely new, and the genetics is new and developing, and the immunology is new and developing, and it's understanding what that means to us as surgeons. So I know that it's coming and that we will have to learn that, but I don't know enough to say where it's going.
So one area that the society can be a leader in, and perhaps hasn't been quite so much, is the whole area of prevention. And do you see any movement to have us have a little more dominant role in that?
Well, I no longer participate on the executive council, so whether there's something going on that I'm not, it's possible the council is doing something. I think locally, colorectal surgeons often are participating, whether they're involved in the Get Your Rear in Gear races or the other kinds of races that are used, or march awareness talks or radio shows or TV shows. I know in our community, and I'm sure in lots of other communities, the colorectal surgeons are very active in participating in that. But I agree that we could be, as a society, doing more. And whether that's public awareness kind of work, or it's more participating more in research into less invasive, broader, applicable, or acceptable to patients methods of screening, I think there are ways we could certainly do better.
There has been a de-emphasis on the anorectal part of what we do, to a degree. I mean, what do you think about it? What has to happen with that?
Well, I'm hopeful that it's just the pendulum swinging, and that minimally invasive surgery, laparoscopy and robotics are the new sexy thing, and that it will swing back. Because I agree that part of what if we're defined by how we take care of colorectal cancer, the surgical part of inflammatory bowel disease, then at least 30%, if not more, of what defines us is that we take care of anorectal disease well. And I hope that as the pendulum swings back from we're all fascinated with the new and latest and greatest toys, that will be recognized again. And certainly that its emphasis, the importance of it continues to be emphasized in our training programs.
Mm-hmm. So your household is a two-surgeon household. How has that been?
It has its ups and downs. The really nice thing is you can go home and talk to somebody who gets it, who knows what it's like to have a difficult time in the operating room, or to run late because the operating room was running late, or to be worried about a patient who isn't doing well. And the hard part is managing the balance, the two people's schedules who are not strictly 9 to 5, how you fit the kids in, and some time for each other, and knowing that you can't do all three equally well all the time, that you've got to be resilient enough to live with that sometimes one thing takes more time and sometimes others. And I feel lucky that we've been able to do it. So the challenge was worth it in our case, but I know that it's hard, and marriages don't always survive that.
True. So if you were to be able to write in the history books your legacy?
I would like it to be, certainly at least relative to surgery, I would like it to be that I took excellent care of patients, that I cared about my patients and they knew that, and that I was a mentor and educator for young people in colorectal surgery.
Is there anything else you want to say, talk about?
I would only say that I'm very happy with the choice. What I do. I love what I do. I've been honored and privileged to have various roles in this society, which has been great for me. I can't say I wouldn't change anything of any of the little daily things that have happened in my life, but overall, it's a great honor and privilege to take care of patients, and this has been a way that suits me.